Hello and good morning. Welcome to the second webinar from our Beyond Blood Sugar, titled From Sugar Highs to Fat Fries, the latest in diabetes and lipid management, webinar series hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. Of note, on March the 4th, we'll have our third webinar focused on your dilemmas. That's not just physicians, that's also allied health professionals. So think of your real life cases that you're dealing with and send them to us, and we'll incorporate those into our March 4th presentation. My name is Donna Manca. I'm a professor emeritus, a family physician, a network director of the Northern Alberta Primary Care Research Network, and the director of quality improvement in the Department of Family Medicine, as well as a medical director in the Physician Learning Program and L3 Learning Program. The Physician Learning Program and Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everybody committed to providing the best clinical care for our patients. Housekeeping, we're going to start with a land acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Métis, Stoney, Diné, Iroquois, and Ojibwe, lands that are now known as part of Treaties 6, 7, and 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, history, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. For more housekeeping information, I would like to let you know a little bit about the features. Please use the chat feature if you have a question about technical difficulties or the L3 programs or services, unless otherwise instructed. If you have a question for speakers, please use the Q&A, the question and answer feature of the webinar. Look at what has already been asked and upvote those questions that you would like answered. We cannot guarantee that we will be able to respond to all of your questions, but a recording of the webinar will be sent by email to all of you who have registered. Participants can claim CME credits and complete a personal development activity using My Lifelong Learning Plan tool. For more information, visit the QR code on the screen. This activity has not been formally reviewed by the Canadian Family Physician College or the Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants can also earn additional certified credits by completing a linking to learning exercise. So today we're very pleased to welcome Dr. Darren Lau and me. We will provide an update from sugar highs to fat fries, the latest in diabetes and lipid management. Dr. Darren Lau is an assistant professor, a diabetologist, general internist, and a clinical epidemiology at the University of Alberta Hospital and the K Clinic. Darren is also an acting medical director in the Physician Learning Program and the L3 program. Apart from his incredible research on outcomes of medical therapy in adults with diabetes, he enjoys sharing the newest, greatest things in diabetes care with anyone who will give him the time of day. So do that. Thank you very much for your time and welcome everybody to our PLP webinar.
Hi, all. Thanks for that introduction, Donna. I am just going to take a moment to screen share the slide deck here. I think it's this one. All righty. I hope everybody can see it. And in the meantime, I realize I need to be able to see the chat. Where did that go? There we go. Okay, perfect. Good. Okay. As Donna said, I'm Darren Lau. I'm at the University of Alberta K Edmonton Clinic, and it's my pleasure to be here today with Donna to talk to you about dyslipidemia management in adults with diabetes. I do now have a disclosure. I have become involved in a small investigator-initiated research project that has received a small number of dollars from Bayer Pharmaceuticals, the maker of finerenone or Kerendia. Otherwise, I have no other disclosures to present.
And I have no disclosures.
So here are our objectives for today. First, we're going to discuss approaches for managing dyslipidemia to reduce cardiovascular risk in high-risk individuals, including the role of newer agents. So we'll be talking about things as well like PCSK9 inhibitors and icosapent ethyl. And again, the point here isn't necessarily to treat numbers. The name of the game is cardiovascular risk reduction. We are going to discuss and debate practical prescribing of things like statins and newer agents and the barriers encountered in real life. And we might then contemplate how we ensure that all the patients in our practice benefit from dyslipidemia management. So the big goal here is that you take away something, you do something a little differently in your own practice, but the icing is if you can figure out how to do it for more than one person in your practice. And we have some tools for you. This is the motivating case. And this is a case I get very frequently in practice. I run a very small academic practice at K Edmonton Clinic. It's a bit boutique. A major source of referrals for me is actually cardiologists. So, there's a number of local cardiologists here who know me and send me their tricky patients who they can't get to LDL values that they're looking for, or who have diabetes and high A1Cs. So this is a typical patient I might see, a 57-year-old male who's had an NSTEMI about 6 months ago. He's East Indian. He had a single stent put in, but there are multiple residual 40% atherosclerotic lesions, and so those would not be considered flow limiting, and he doesn't have any symptoms of angina. His EF on the echocardiogram during this admission was 55%, so no real heart damage from this episode, thankfully. His past medical history is consistent. It consists of hypertension, dyslipidemia, type 2 diabetes, and of course, coronary artery disease. And here are his medications: aspirin, ticagrelor, pravastatin, perindopril, metformin, gliclazide, bisoprolol, and empagliflozin. He's a university mathematics lecturer, and he does have a family history of early onset cardiovascular disease and diabetes. His physical exam findings and his laboratory investigations are shown there. Okay, I do want to, like last time, I don't know how many of you were here for the talk last time on kidney care, but I do like to have some interactivity. So I am going to let you guys, you all in the audience, digest these labs, digest these numbers, and comment on things you notice, things you think need to happen for this individual, things you're concerned about. Sky's the limit. And there's two ways to comment. You can raise your hand and we can grab you to say a thing or two, or you can put it in the chat, and the chat's been opened up for this purpose. So take a moment and go ahead, have a look through. Now I got to figure out how I can see participants on my Zoom. How do I do this? It worked when I wasn't screen sharing. Oh, there we go. Perfect. There is one hand raised. Oh, here we go. Abimani, you have a hand raised. Are you able to unmute and go ahead?
Okay, so I'll just go through the values that you showed us. I'll start at the top there. His blood pressure is not on target. Would want a blood pressure of balance chart over 8 or less. Whether it's diabetic, got diabetes, sorry, not. So that's not on target. We need to work and get that better. The next one on the list is EMI. Again, that is again off. I want that under 24, precisely 18 to 24. The A1C is no doubt out of hand, so it's not the diabetes is not controlled. We need to work and get it better. Now, is GFR, I think for now looks fine. USCR is pretty good, so we step there. But if we don't work hard on his diabetes, we may get into trouble.
Well, you've highlighted a number of things so far. I'm curious if you could pick one next thing that you want to talk to this patient about. What would it be?
I probably would start with the sugar.
Okay, you'd start with the
blood pressure is certainly a problem because I mean both of them are critical to preservation of both his kidneys, but also his heart attack.
That's very fair. And I know this is a talk that's meant to talk about dyslipidemia, but we have to remember that cardiovascular risk reduction is a holistic thing. And so, yeah, we do need to control the other cardiovascular risk factors. So blood pressure is important. And in this patient, we would target 130/80 for the diabetes. But the other important one, the other important one, as you pointed out, is, A1C reduction. And so you look at this patient, you think, what am I going to do from a diabetes or an A1C perspective? You know, there's a couple of easy answers here. And those easy answers would be, don't forget, SGLT2 inhibitor and GLP-1 receptor agonist. He's already on EMPA-10, but EMPA-10 is kind of like the cardiology dosing of empagliflozin. You could go to EMPA-25, and with his preserved GFR, like excellent GFR, he'd actually have some pretty good blood sugar lowering from making the switch from EMPA-10 to EMPA-25, for sure. And then consideration of semaglutide, GLP-1 receptor agonist. And I like these options because no matter what their A1C is, you know, I'm going to be doing this for cardiovascular risk reduction, right? In the context of a patient-centered conversation. And so that's something we'll talk about more. Yeah, but absolutely. Thank you for that, Eben.
Just one observation. I don't know you guys are in Alberta, but here I'm in Saskatchewan, and sometimes there are problems with some of these medications in terms of coverage. You know, we have challenges, you know, starting somebody SGL2,
yeah, absolutely.
I don't know what you have in Alberta. How are you doing there?
Man, you should be aware that dapagliflozin is generic, so it's probably covered by Blue Cross as a regular benefit. It is in Alberta. I imagine in Saskatchewan there may be something similar. I don't know. Saskatchewan. I'm not sure how the insurance system works in Saskatchewan, but that's a fact of life. We do struggle with this. Yeah, and we'll talk a little bit more about that later. Yeah. Any thoughts from other members of the audience? If you don't want to pipe up, feel free to type something in the chat. Anything about this case? Any interesting thoughts? Any considerations for what to do next? How would you approach this case? Is it too early for audience participation? I see a hand up from Jaya Pillai. Go ahead, Jaya.
Just wondering why the patient is only on metformin 500 BID.
Fair point. Might have been that's a good question. Maybe it wasn't titrated, maybe medication side effects. Yeah, that's but you know what? If I were to look at that med list, the more glaring feature would be why the patient's only on pravastatin 20, right? I think that's the more glaring feature here. And we do see this a lot. Usually for me, pravastatin and simvastatin, pravastatin being lower potency, simvastatin being moderate potency statins, they were more common about a decade ago. But these days, when I see someone on pravastatin 20, like a low dose of a low moderate potency statin, it's almost certainly a tip-off that they've had statin-related side effects. So now we know, okay, this might be a barrier to to cardiovascular risk reduction is that this individual has had statin-related issues. Yeah, Nandini writes, could rotate Prava to atorvastatin? Absolutely, absolutely. When I have a look at this case, one thing that strikes out is, what dyslipidemia target am I aiming for? Jaya, you can mute your mic, please. But thanks for that comment. And okay, so this lipid panel, it might be typical of a lipid panel I see. And we often see this, the LDL unable to estimate. What does that mean and how do I deal with it? Okay. Well, LDL continues to be the centerpiece of dyslipidemia management because it has been for a very long time and because it shows good prediction of future cardiovascular risk, LDL referring to one of the fraction of lipoprotein particles that are atherogenic and circulate in the blood, and because intervening on it can make a difference. So these are data from experimental trials, so the statin trials, and the meta-analysis of them show that every 1 millimolar reduction in LDL achieved with statin therapy reduces cardiovascular risk by 20%. And again, this is high-quality randomized controlled data. And in fact, there really is, to our knowledge, no lower limit in adults of how low you can drive an LDL. For example, in the Fourier trial of a PCSK9 inhibitor, LDL-C was actually lowered to 0.9 millimolar on average compared to 2.3 millimolar in the placebo arm, and there was still a 15% relative risk reduction in cardiovascular outcomes. And in that trial, some individuals actually had LDL less than 0.4 millimolar per liter. So LDL does remain the mainstay of our targeting for dyslipidemia management and cardiovascular risk reduction, but when the triglycerides are high, sometimes the lab assay is unable to estimate an LDL fraction apart from total cholesterol. But moreover, if the triglycerides are high, some of the cholesterol in these LDL particles is actually replaced with triglycerides, leading to smaller, more atherogenic particles. And as a result, the same LDL might not mean the same thing for cardiovascular risk. It might actually underestimate cardiovascular risk in the context of a high triglycerides. I do see we have some comments. I'm going to come back to the case in a second, but I just want to we're just going to finish this thought here. So there are a range of other non-LDL atherogenic lipoprotein particles in the bloodstream. They include things like IDL and VLDL. And so together you might consider targeting a non-HDL cholesterol, which is the sum of all the atherogenic lipoprotein particles in the blood. And because it captures these other particles, non-HDL cholesterol actually demonstrates superior prediction of cardiovascular risk versus LDL cholesterol and is more often available in the context of high triglycerides. And so our primary prevention targets for LDL are 2.0. Secondary prevention, we target 1.8 millimolar per liter. These are straight out of the CCS guidelines. For non-HDL cholesterol, we would target 2.6 for primary prevention, 2.4 for secondary prevention. Sometimes if the triglycerides are quite high, we can't measure any of these, we go to ApoB. So ApoB won't be reported on your lipid panel, but you can order it separately for your patient. It is covered by Alberta Health. And the point here is that every atherogenic particle has a single ApoB moiety stuck to it. So ApoB actually represents the best indicator of atherogenic particle numbers and predicts CV risk better than non-HDL cholesterol, where the results are different. And for ApoB, we would target 0.8 for primary risk reduction and 0.7 for secondary risk reduction. Okay, some comments here from Vishnu. EF is 55% beta blocker. Is it needed? That is a good question. Patients are often started on beta blocker after acute cardiac events based on evidence that actually predates our current era of, ACE inhibitor, ARB, and these sorts of things. So this is hotly debated by the cardiologists. I think current practice is to have people on it, but then to be willing to deprescribe after about a year's time. Would look to reduce BMI going over lifestyle. Yes, Donna's going to talk more about that for sure. Okay, so in terms of LDL, okay, so if we look at this patient and we look at the math here, we can see his non-HDL cholesterol is actually blippingly high Total cholesterol minus HDL cholesterol gives us 4.08, which is a far cry from the target of 2.4 in this patient. So we've got a lot more work to do. What can we do to get more LDL or non-HDL cholesterol lowering in this individual? Well, statin therapy continues to be the mainstay of treatment. And again, that's based on really good evidence from multiple trials that statins make a difference. In diabetes specifically, we have the CARDS trial of atorvastatin, and the number needed to treat over 4 years there was 32, which is amazing. But again, the hint here, he's on pravastatin. The hint here is that he's had statin-related side effects in the past. It's worth knowing that trials of this have been done, and 80% of statin side effects would be what you could consider nocebo side effects. So they're actually observed in patients who were treated with placebo, as opposed to with the statin, and are indistinguishable either on symptom intensity or relief with stopping after you withdraw the quote-unquote agent, so the placebo, right? These things don't actually distinguish whether someone's in the placebo arm or in the statin arm if they have muscle aches as a side effect. And in fact, for individuals who have side effects on statin in these trials, 50% of them, over 50%, some estimates as high as 80%, are successfully able to restart statin therapy and continue it long term, okay? That's not to say that these side effects aren't real. You know, I live in a tertiary care environment, so by the time patients are referred to me for these sorts of things, they've had multiple trials and they're really struggling. I get it. You know, many patients do have real or practically real side effects on these agents. But my approach is typically to get a detailed history of what statins they've been on and the side effects, and to retrial high-potency statin therapy, even at lower doses to begin with. And then any statin's better than no statin. So this table here is provided for your reference. It's just an indicator of the average LDL relative reduction you expect to see with different statins. And again, pravastatin would typically be considered one of the lower moderate potency statins compared to rosuvastatin or atorvastatin. And this guy's had a heart attack. You really want to try him on atorva, rosuva, maybe even starting at the lower doses there. But there are some patients who you don't get to target on statin therapy, or who really don't tolerate statin therapy. And so what are your next lines of therapy? Ezetimibe is something we always go to, and that's because it's inexpensive. There is cardiovascular outcome data showing that it makes a difference, although that difference is actually, relatively speaking, fairly small, okay? It does work. It lowers LDL cholesterol, but really, depending on how far away they are from target, I use ezetimibe for sure, but you know, I might go to it if there's only little ways to go to get to target, or if it's required by drug insurers. Very often, drug insurers will require someone to be on ezetimibe before thinking about other agents. But the new kid on the block, and we've had great success in my clinic and in dyslipidemia clinic at the U of A Edmonton Clinic with PCSK9 inhibitors. So these are typically injectable agents. They're monoclonal antibodies that reduce expression of the HMG-CoAs in a different manner than statin therapy. And the two big ones, the older ones on the market now, are evolocumab, marketed as Repatha, and alirocumab, marketed as Praluent. So these are very effective agents. As I mentioned earlier in the Fourier trial, some people actually got their LDL down less than 0.4 millimolar per liter, which is, you know, spectacularly mind-boggling in terms of the degree of LDL lowering. And so these are some data from the Fourier trial and the Odyssey outcomes trial. Both of these trials enrolled individuals with cardiovascular disease and additional cardiovascular risk factors. So high-risk patients, high-risk patients. And you can see in these individuals treatment with evolocumab and alirocumab. I apologize for the difference in the axes, so just watch out for that. But did produce major adverse cardiovascular event benefit with hazard ratios indicating a relative risk reduction of about 15 to 20%. Over 3 years in the Fourier trial, number needed to treat would be about 50. So that's favorable by considering that this is residual cardiovascular risk after attempts to optimize everything else. PCSK9 inhibitors, though, are, again, injectable agents. This is what Repatha looks like. This is what Praluent looks like. They're very well tolerated. From a safety perspective, you know, I mean, there were side effects in the trials, but they tend to be balanced between, intervention, so the PCSK9 inhibitor and placebo, so things like nasopharyngitis or influenza-like symptoms or myalgias or arthralgias, they did occur, but again, they were similar between groups, and no differences for the key safety outcomes of rhabdomyolysis or elevated AST, ALT, or CK levels. I do note that about 2%, so what is that, 150 individuals have injection site reactions with these agents, as you might expect. In my practice, somebody with terrible muscle aches on multiple statins, on even low-dose statins, I've had individuals go on evolocumab and alirocumab, and for them it's like injecting water, but the next LDL is cut down by easily by half or more. So I've had a great luck with these agents. Again, recognizing that I'm an academic practitioner with a low volume practice, but we've had good luck with these agents in getting LDL down. Funding is going to be an issue though. And so if they have private insurance, yeah, you can get coverage for secondary risk reduction. It's a bit of paperwork. It's a bit of work on the patient's part and on your part, but if they have private insurance benefits, if through work, for example, or maybe they maintain their work-related coverage after retirement, you know, you got a good chance of getting this covered for secondary risk reduction. Unfortunately, public Blue Cross will only cover it for familial hypercholesterolemia, according to probable or better on the Simon Broom or Dutch Lipid Network criteria. You can look these up to see if your patient qualifies. As a rule of thumb, you know, if they've demonstrated an LDL greater than 5 at any point in the past, you got a pretty good chance they're going to be probable on these criteria, and you're going to get coverage that way. And other elements of these criteria include things like a really strong family history of premature cardiovascular disease. Now, you might have noticed that this patient had elevated triglycerides, 3.2, okay? Triglyceride lowering is still a little controversial, right? So, you know, a moderate hypertriglyceridemia might be 1.7 to about 5.6 or so, moderate to severe up to 11. Severe is definitely 11 or 12 or higher. And, you know, at the point of being 11 or 12 or higher, you really worry about acute pancreatitis risk. That patient needs a fibrate for sure. But for lower degrees of hypertriglyceridemia, which we commonly see, the pancreatitis risk isn't really a thing, and we're more interested in cardiovascular risk reduction. So we know that elevated triglycerides is associated with cardiovascular risk. It's a big risk factor, but the evidence is quite mixed on whether treating that high triglycerides, like getting it down, actually improves cardiovascular risk. So for example, we have a recent fibrate trial with pemafibrate, where the hope was that this would confirm in high-risk, high triglyceride individuals that lowering their triglycerides with pemafibrate would reduce cardiovascular risk, but that was not borne out in the trial. Some trials bear it out, some don't. The ones that don't suggest that it might be borne out in the subgroup of individuals with really high triglycerides. This is a bit of a mixed bag for fibrates and triglyceride lowering in terms of reducing cardiovascular risk. Still a reasonable thing to do for individuals with really high triglycerides, like 2.3 or above, but that's at your discretion. Certainly something that you have to do above 11 because of the pancreatitis risk, right? But we do have a new agent that's indicated in individuals with high triglycerides, and this is icosapent ethyl. So omega-3 fatty acids are another class of medication, so to speak, where we really don't recommend it for cardiovascular risk reduction. Most omega-3 preparations are mixed and have not shown consistent benefit in the randomized trials, with the exception of the GELIS trial, which used a fraction of the omega-3 fatty acid, the icosapentaenoic acid fraction, and actually did meet its cardiovascular endpoint. So building on that, we have in 2017 the REDUCE-IT trial, and this was a trial of a new synthetic drug product called icosapent ethyl, which really is icosapentaenoic acid, but synthesized and purified. So not really talking about fish oil anymore. This is truly a new drug product. It's administered as 2 grams BID, and they come in these 1 gram tablets. So it's kind of like being on metformin. And, you know, it's four capsules a day. And this trial was placebo-controlled against mineral oil. It enrolled individuals with high-risk features, so previous cardiovascular disease, or age 50 plus with diabetes and additional risk factors. And they all had to have an elevated triglyceride of greater than or equal to 1.7, as well as reasonable LDL on statin therapy, okay? And the REDUCE-IT trial actually showed, again, cardiovascular benefit in individuals treated with icosapent ethyl. At about 5 years, the number needed to treat was 28, which is actually quite remarkable. Interestingly enough, the cardiovascular benefit seems to be unrelated to the degree of triglyceride lowering. So it might not actually work by lowering triglycerides. It might work by other mechanisms, including membrane stabilization and atherosclerotic plaque. And there is actually imaging evidence, placebo-controlled trial imaging evidence, showing that icosapent ethyl can reduce low attenuating plaque, whereas placebo-given patients actually showed an increase in low attenuating plaque over 18 months in the coronary arteries. And of course, that's not the hard calcified stuff. That's the stuff that we care about. It's young, it's fresh, it can pop and cause acute myocardial infarctions. In terms of safety, we do note that there is an increased risk of AFib and hospitalization for AFib in patients treated with icosapent ethyl. That risk was 5.3% versus 3.9% over the course of the trial. But most of us worry about AFib because of the implications for stroke. And again, icosapent ethyl was associated with a net reduction in major adverse cardiovascular outcomes, including stroke. This is a very expensive medication, costing about $300 a month, but it is actually Blue Cross funded for seniors, age 45 plus, for secondary risk reduction in individuals with triglycerides greater than 1.7 on statin therapy. But of course, this is a patient-centered conversation to have because it does increase the pill burden remarkably. I want to pause there. We've talked about triglycerides and LDL lowering. Any other thoughts from the group? When I look at this patient, I just want to shout out to our talk from last 3 weeks ago. I do notice that the eGFR is quite good, but hey, this patient has albuminuria. So addressing renal risk might be a consideration. I refer you to our previous talk in the series, but it's important to remember that ACE inhibitors, ARB, SGLT2 inhibitors, semaglutide, and finerenone are agents that would be indicated here for both kidney and heart risk reduction. So cardiorenal risk reduction. In the interest of time, I'm going to do a bit of summary now. So cardiovascular risk reduction, what are our medical options now? Please do consider tracking dyslipidemia, tracking the lipid panel in your high-risk individuals. And I point this out because I know there's debate in the primary care world about whether you should treat to target the way I typically do, the way specialists typically recommend, or whether you should prescribe and forget. I think these debates are maybe more prevalent in the primary prevention world, but for a patient that's high risk like this, I definitely think you can make an argument for treat to target, because this will help engage your patients. If they see their LDLs getting better on therapy, it might improve medication adherence. It identifies when and where you need to intensify therapy. You can document the benefit of the therapy you put them on, which is actually quite important for the newer agents for funding purposes. And if you treat to target, if you're monitoring the LDL, this gives you a chance to improve the quality of care in your overall patient panel. And now statin therapy is inexpensive, effective, and it's safe, and remains the cornerstone of CV risk reduction, along, of course, with risk factor reduction and ACE and ARB therapy. But I'd like to point out that PCSK9 inhibitors are additional highly effective agents for lowering LDL, and of course, icosapent ethyl lowers triglycerides and reduces cardiovascular risk by other mechanisms and is indicated for hypertriglyceridemia for secondary risk reduction. How often should we monitor after starting statins? Whatever is practical in your practice is the answer to that question. I typically monitor every 3 to 6 months. You should see the effect of starting someone on statins or icosapent ethyl or PCSK9 inhibitor within a month, actually. I do recognize patient-centered concerns here. I've just talked about, a whole bunch of different medications, and I'll be honest, they are a financial burden and they're a massive pill burden. And my patients often come to me and say, "Doc, holy moly, do you see the handful of pills I have to swallow every morning?" So I do really have honest conversations about what patients are willing to spend or tolerate to prevent CV cardiovascular disease, recognizing that we do have the phenomenon of marginal gains as we go along, but residual cardiovascular risk is a real deal, right? And so some advocacy and some having some having of honest conversations and risk evaluations with your patients is necessary so that you avoid this outcome depicted on the left side, and so that your practice looks a little bit more like this on the right side. Okay, over to you, Donna.
Okay, so something we didn't talk about here is metabolic syndrome. And you may or may not be aware that not all diabetics have metabolic syndrome, and not all slim, healthy looking people do not have metabolic syndrome. So metabolic syndrome consists of 3 out of 5 criteria. And I'm showing a table from a paper that we published where we developed an algorithm to identify patients in the EMR who have metabolic syndrome. You can see that this fellow checks 5 out of 5. So he clearly had metabolic syndrome and had it before he developed diabetes. And I find often if we address this early on, we can even prevent diabetes. So lifestyle modifications are huge, both after they develop diabetes, but even if you can do it before. So metabolic syndrome has risks for numerous other conditions as well. Next slide. So with this fellow, I think it would be really important to look at lifestyle. Maybe he's drinking. If he's consuming a lot of alcohol, that could certainly be a big factor in his elevated triglycerides. But so is the sugar content in the food. And people don't realize how much sugar they're often eating. He may not be exercising at all. And then, of course, he might be smoking. Next slide. There are a lot of other things to consider. When you have metabolic syndrome, you're more at risk for fatty liver disease, and we know that causes cirrhosis, and I've had patients with liver transplants due to this. So it's important to look at liver function. You may want to look at other things like sleep apnea and others. Next slide. So with this fellow, again, if he's drinking alcohol, I really try to get him off all of the alcohol and smoking. A diet, Mediterranean diet and DASH diet work. Lower carbs. There's restrictive eating that can be beneficial as well, and increasing fiber in the day. He really should optimize his medications. The statin, there's something going on there. So you find out it maybe didn't tolerate it. Start at a lower dose, maybe. I find sometimes I have patients, they're started off on the highest dose and they don't like it and stop, So I often titrate it up. He should be on an ACE-ARB, which he is. Glycoside, not good. Not good for metabolic syndrome. Be better to increase the SGLT too, and possibly add on a GLP. You can use both, and that could benefit him quite a bit. I'd work with the cardiologist on whether he needs his antithrombotic therapy and for how long, as well as what other lipid-lowering considerations we might have. Next slide. I find with a lot of these patients, we're dealing with a lifestyle and behavioral change. And something that works very well, grounded in the science, is motivational interviewing. However, that takes an inordinate amount of time. And it's not something a lot of us can do in our practices. I found brief action planning worked very well and can be done at a regular visit. I'm showing a screenshot, and there's a link that you can go to learn how to do this. And it really is around having the patient identify what they are willing to do to change, what they're interested in changing. And then evoking from them, what they will do, as well as how confident they are they can do it, and it works you through a process of increasing that and the likeliness of improving their behaviors. Next slide. Having a treatment plan is really important for both you and the patient. And I find it's really helpful if there's something that can be written out that can be handed to the patient, as well as for you to share with your team and to keep on the chart so that everybody is on the same page. And this is something you'd update at regular visits. And the Diabetes Canada has an excellent care plan that you could tailor for this use. Next slide. Now, we're talking about an individual patient, but often it's important to know how we're doing in our panel. And this is around getting data and information and looking at improving our care. Next slide. The Canadian Primary Care Sentinel Surveillance Network was developed by a number of research directors of practice-based research networks across Canada in departments of family medicine. And we developed the ability to extract point-of-care data from the electronic medical record, structure it, and use it for surveillance, quality improvement, and research. Next slide. The Northern Alberta Primary Care Research Network is a network that's contributing data to the CIPSIN, and it can provide information to participating physicians and nurse practitioners in the network. In Southern Alberta, there's SAPCRIN, the Southern Alberta Network, that also does this. Next slide. So this is an example of information we can look at for individual physician. The physician is the dark blue. This is what's coded in their problem list. And this physician, you can see 100% of their diabetic patients are in their problem list. That means that they have a disease registry. They can look up easily in their EMR who has diabetes. And whoever's coming to see those patients can see on the chart that that patient has diabetes. Good data management is really important to good care. Next slide. We also provide physicians with reports. PLP and NAPCRIN are working together so we can provide point of care information on how the physician is doing. And these are an example of a few reports that physicians could receive on their care. The physician is the dark blue color, and you can see in the diabetes and diabetes with renal failure, how many of them are optimized. And that physician was able to improve medications to their diabetics with renal failure using the data and inviting those patients in through quality improvement. Statin use in adults with diabetes in the network is not very good, So we know most of our diabetic patients probably should be on a statin, and overall it's around 60%. And you can see here this physician's around over 80%, with the information from the data. Next slide. So I encourage you to consider about contributing to family medicine and primary care research. And this is shows a mountain on how you can contribute just through being engaged, contributing data, and joining the network. Next slide. Another excellent resource is the Health Quality Council of Alberta. And you can see a very similar report on the Lipid. This is the same physician, where that physician is achieving 80% of statin prescribing in their diabetic patients over 40, as compared to around 60% of those patients in the PCN panel. So again, these sources of data can really help you improve practice, and you can use them for improvement as well and reporting where you have to the college. Next slide. So the College of Physicians and Surgeons require us, the clinicians, to do 3 quality improvement projects over a 5-year cycle. And the practice-driven QI project can really benefit from use of these information sources. And you need to use data, develop an action plan, and ideally it could be facilitated by someone in your PCN, but not necessary. You can do it on your own. And then you implement and reevaluate. Next slide. The Federation of Medical Regulatory Authorities of Canada developed this 5-step system for improvement. So this is the process. This is how you go about improving. And it's grounded in the CanMed roles. So improvement you can't do in just a day. You have to first understand what the problem is, assess it. Then you develop a learning plan, You implement it, test it, and evaluate the outcome. And you can capture that information in the My Lifelong Learning Plan. Next slide. So this is a free online tool that can help you facilitate and capture the information that you need to document when you are reporting on your quality improvement activities. And the great thing about this, it's also got Main Pro Plus credits. So Family Docs, for your practice-driven project, you get 24 Main Pro Plus credits. And for the personal development and standards of care improvement projects, you get 6. Next slide. So to register or get more information about this tool that you can use for your quality improvement, you can scan this code or visit the link. And this will be included in the webinar information that's passed out. Next slide. And Darren, take it away.
Okay. So in summary, this talk was about cardiovascular risk reduction, high-risk individuals with dyslipidemia, specifically focused on an individual with diabetes, but not necessarily limited to such an individual. And I guess my take-home points would be as follows. A holistic approach to patient-centered care, including lifestyle modification and behavioral assessment and risk reduction, is important. As Donna's mentioned, and as I think let's see, as Babatunde's mentioned as well in the chat. Statin therapy, ACE-ARB, and other risk factor reductions, so getting that blood pressure down, A1C down, etc. These things continue to remain foundational for medical care. They're the basis on which other things are added. If you need them, PCSK9 inhibitors and icosapent ethyl are new agents for secondary risk reduction. But of course, addressing residual risk with these agents does require monitoring, advocacy, and balancing patient-centered concerns, including very real concerns about side effects, pill burden, and affordability. Resources are available. So if you need help with prescribing pathways and knowing what the cutoffs are, Canadian Cardiovascular Society has an excellent version of their dyslipidemia guidelines in a little booklet. It's very pictorial, so you can just walk your way through them. And that's available on the Canadian Cardiovascular Society guidelines. We'll put a link to that for you and some resources that we'll email out to you after this talk. And of course, there are additional resources for practice assessment, benchmarking, and to help you develop targets for practice level improvement, as Donna has just discussed. I'd like to thank you all for your time today. And if you have any other questions or comments, please feel free. Don't forget, we're doing this again, March 4th. There's another one of these talks, last in the series, number 3. And we haven't had any cases so far. The point of this is diabetes dilemma. Bring your own cases. I mean, Donna and I will have cases as well. And, you know, I'm happy to talk about my other passion is continuous glucose monitoring. So we'll have something, but even better if we can address the things that bother you in clinical practice. So please, the dilemmas you encounter, you know, get them out to us in anonymized terms, in general terms, please. We don't need to violate patient confidentiality for continuing medical education. But please, please, please get them out to us. We'd be pleased to discuss your cases as a group. Okay, it's kind of like the chance to have a consult without having a consult. You know what I mean? I see messages and a hand raised.
Yes, we'll move on to the question and answer. And there's some questions in the question and Q&A, so we encourage you to put in your questions. And the first one is, do look at L-lipoprotein A for your patients regarding cardiovascular risk, and how do you manage it? So that's to you,
Knew
Darren.
that was going to come up. I knew that was going to come up. Here, I have a slide on it.
Right?
Lipoprotein A is going to be a big thing in the future, but right now it's interesting. So the idea of lipoprotein A is that lipoprotein A concentrations really vary among people. And they vary in ways that are not affected by lifestyle and statin therapy. In fact, lipoprotein A is primarily genetically determined. And actually, there are some very clear differences from populations to populations across the world. that might account for some of the ethnic differences we see in cardiovascular risk, apart from environment and diet and these sorts of things. So having an elevated lipoprotein A is a risk factor, but it's not at this time a modifiable risk factor. So you might do it to pin down someone's cardiovascular risk better, because if it is elevated above 100 nanomolar per liter, that person has a 1.5 to 2-fold increased risk of cardiovascular disease on top of their risk prediction based on LDL cholesterol and other Framingham type risk factors, right? So, you might measure it once in a patient's lifetime to help with cardiovascular risk assessment, and then to enlist them for additional cardiovascular risk reduction, for example. But the role of Lp(a) is going to change in the future, because we do have therapies targeted against Lp(a) in trials right now. So it may in the future be something we can target with therapy, in which case Lp(a) might become something you monitor more routinely, the way we might do a non-HDL cholesterol and LDL cholesterol. But right now, its role is mostly in understanding cardiovascular risk, and it's recommended to be measured once in a lifetime because it's primarily genetically predetermined and not affected by statin therapy or lifestyle. I hope that answers your question.
And the other is from Bishuni Bandari. I hope I pronounced names okay. It's more common, ezetimibe, well tolerated, no side effects.
Ezetimibe has a side effect profile that's very similar to statins. Muscle aches are an issue with ezetimibe. I find that it's not a guarantee that someone with muscle aches on statins will also have muscle aches on ezetimibe. In my experience, it tends to be, it's not a guarantee. I do have individuals who are like sneaking by on the lowest dose of pravastatin who do tolerate ezetimibe quite well. But equally, I've had individuals who have had muscle aches as a problem on both types of agents. So it is worth trying. But you know what? Part of doing this is having a practice where you can have that follow-up and have these conversations and bring people back in a timely fashion to reevaluate the outcomes of, trials of withdrawing a medication, re-challenges, so this becomes quite a journey with your patient, right? From a practice organization perspective, even at the specialty care level, I find this challenging. It's not straightforward.
And we have a question from David Ugo Chukwu. What level of urinary creatinine should be or should not catch the physician's eye in the previous CV incident? I'm asking this in respect to balancing the pill loads of the patients when they are concerned.
Yeah, that's fair. Look, when I know Diabetes Canada says, you have CKD above 2. Most nephrologists say CKD above 3, right? But we have some individuals who have like a 4.5, or who kind of have up and down, and sometimes it's, 1.5, sometimes negligible, sometimes it's 4. Are we going to go full hog on cardiorenal risk reduction, these individuals? So that's a judgment call. At least they should be on ACE-ARB, SGLT2 inhibitor if they have diabetes. In my mind, those are the easy ones to put on, right? Definitely when we get into the double digits, that is like, okay, got to fix that, because above 30 is considered severe albuminuria. When we get into the hundreds, it's nephrotic range, but above 30, it's considered severe, right? Even above 3, it's considered moderate by KDIGO, the international guidelines. So yeah, there's probably a gray zone in there, but when we start to get above 5 or so, I really do start to push treatment. That's personal. But I do recognize the struggle though, because we've just talked about essentially 5 or 6 different classes of medications, injections and pills. There's some negotiation that has to happen here, clearly. Some patients value cardiorenal risk reduction more. My father-in-law had a parent that went through dialysis, and he is hard set to avoid it. And he tracks his creatinine like nobody's business. So I have him maximized well with his doctor, right?
And Brianne Bannister says, if we're treating to target and once the patient is at or near target, how often, if at all, do you repeat the lipids?
At target or near target, right? Your practice may differ. It just my pet peeve is when patients come to clinic and they haven't done their blood work and they promise, oh, I'll do my blood work this afternoon. Like, that's not helpful, because then I get in my inbox, but I don't have the opportunity to talk to you about it until next time I see you, or I have to call out. Okay, so this is where road hits rubber, right? And as a rule of thumb, for stable adults with diabetes, my practice, I measure comprehensive blood work for diabetes. So, A1C, lipid panel, creatinine, urine albumin, and creatinine ratio. I usually do check electrolytes and CBC differential as well. I'm still a general internist, right? But I'll do that every 6 months for stable patients. For patients where I'm actively managing, because the A1C I check every 3 months, then that's how I tack on the lipid panels. For an individual where you're starting a PCSK9 inhibitor, very often the insurance company will say something like, you get 4 weeks supply, and then you got to reapply for renewal. Okay, so at the renewal, they'll want to see evidence that LDL has come down or the non-HDL cholesterol has come down. So you might actually need to repeat that lipid panel within 4 weeks to make that evidence happen, right? So it varies, but as a rule of thumb, if I'm actively managing someone every 3 months, because that coincides with the A1C.
Yeah, and I think a lot of it depends on so much on the case. If they don't have many comorbidities and that, you may not need to repeat very often at all, right? So a question from Romaine Captain is it true that statin therapy may raise LPA?
I have not encountered that in my reading, but now that you've raised it for me, I will look into it. It is true the statin therapy probably increases sugars by a tiny amount. There is some signal for that. Not enough that I think makes an appreciable impact on treatment of diabetes, though. And overall, the name of the game is cardiovascular risk reduction, right? No, I haven't encountered that. It is also true that fibrates may raise LDL by a small amount. And so there's some debate with that trial that I had mentioned earlier, the prominent trial, whether there could be some issues related to higher average LDL in the treatment arm. Yeah, I wish I had more to say about that. Sorry, but you were talking about LP little a, right? So my understanding is LP little a is not affected by statin treatment. It is primarily genetically determined. So I don't think that's a consideration. I will look into it. I haven't encountered it. If you've encountered some evidence, email it to me at darren.lau@ualberta.ca. Okay, we can have a conversation. But my understanding is LP little a is not affected by statin therapy.
And then we have an anonymous attendee who says, how likely are you to take this patient off glycoside and increase the dose of SGLT2 or reduce or adding GLP-1 agonists, considering the risk of hypoglycemia and beta blocker masking hypoglycemia and no cardiovascular benefit with glycoside?
Exactly that.
Right? Right? Yeah.
I love it. Thank you for pointing that out. You got to come up here. You should be up here.
Yeah. And then we had one hand up, and that was Rebecca Bondar.
Hey, Rebecca. Oh, mistaken hand, maybe?
Yeah, maybe. We have another comment from the anonymous attendee. Twice in recent memory have had patients with no coronary artery disease history have their statins reduced, on hospital discontinued because they're low LDL around 1.1. Have you seen this, or can you explain the rationale?
Yeah. I don't know the context of those cases. It may be a much older individual where the attending physicians were really thinking about de-prescribing agents. We have to strike that balance of pill burden and side effect burden in our older individuals for whom life expectancy is limited and the incremental or marginal benefit of therapies like this becomes a bit smaller when competing.
Oh, and they did have a history of of cardiovascular disease.
Yeah.
Yeah.
Yeah. So it may also have been a patient-centered concern as well. Like the idea is they should probably stay on a statin 100%. But do you need to stay on a statin at the same dose if the patient's, for example, quite an older individual who's concerned about myopathy or muscle wasting, right? And again, we don't have great evidence that's, like statins are safe, right? But we do get patient-centered concerns about this all the time. And if their LDL is 1.1, it might be a patient-centered decision to relax the dose. But to discontinue it fully seems, unless they were truly having side effects or they were really worried about pill burden. I hope there were some conversations that happened for that patient because, our current evidence suggests that, again, you can lower LDL down to 0.5. And there has been no evidence that it increases the risk of things like dementia, for example.
Yeah.
And people have looked at this. So it would be safe to have an LDL of 1.1. And you know what? The cardiovascular risk reduction, because if they're functional individuals, statins help prevent strokes too.
Yeah. It's weird. Well, and I think that is our Q&A and our webinar. So thank you everyone for your great involvement in this webinar, and we appreciate your feedback. There is a QR code on the screen. Please take your time to give us feedback. It helps us improve and develop even better webinars. So thank you again, and remember to bring your questions. Send your questions to us, and we'll get that incorporated into our March the 4th webinar.